Good afternoon, everyone. Acute vestibular syndrome. This is the topic I am going to discuss for another 30 minutes. In mid 80s, when I was a undergraduate medical school student, we were told that an isolated vertigo is never a symptom of cerebrovascular disease, TIA or stroke, and a term called reversible ischemic neurological deficit was in use at that time, but is no longer used now. However, a study from the South Korea found that acute infarction in at least five regions of the brain can result in isolated vertigo without any other clinical symptoms or signs. These five places are nodulus of the cerebellum, lateral caudal pons, that is the root entry zone of the eighth cranial nerve, flocculus, vestibular nucleus, and the parieto-insular vestibular cortex, which is also known as the dorsal insula. The hints examination, which we are going to discuss at some length, is not useful in detecting acute vertigo syndrome resulting from acute infarct in the dorsal insula. Unfortunately, the MRI brain diffusion weighted imaging conducted within 48 hours of the stroke is falsely negative in 12 to 18% of the acute vestibular syndrome patients. So, there is a strong evidence that indicates when the well-trained service providers perform a high-quality bedside neurovestibular examination, the accurate diagnosis of both peripheral vestibular disorders and the stroke increases significantly. This is a study from the John Hopkins, the Newman-Toker's lab. So it proves that the sovereignty of the clinical medicine prevails. In year 2022, there was a significant shift in our understanding about the isolated vertigo as a cause of stroke, and the criteria for the vascular vertigo and dizziness were laid down by the Barani Society. The acute prolonged vascular vertigo or dizziness criteria A to C should be fulfilled. The first is acute vertigo, dizziness, or unsteadiness lasting 24 hours or more. Imaging evidence of ischemia or hemorrhage in the brain or inner ear, which corresponds to the symptoms, signs, and findings. However, at what time the imaging has to be done is not made specific in these criteria, not better accounted by another other disease or disorder. So, David Newman Troker added nystagmus to this definition. Acute vestibular syndrome is a clinical condition characterized by dizziness or vertigo that develops acutely over seconds, minutes, or hours, is accompanied by the nausea, vomiting, gait instability, nystagmus, and head motion intolerance, and persists for a day or more. So, by adding nystagmus, a nystagmus is necessary for the hints examination. Without nystagmus, the hints examination is of no use. So, AVS, the biggest challenge for any general neurologist is to differentiate acute vestibular neuritis from posterior circulation stroke. And if any journalist he knows how to differentiate it by the hints examination, he has an advantage. The triggered acute vestibular syndrome is due to overlap syndrome with trauma and traumatic hemorrhage, subdural or subarachnoid, and it is not a topic of discussion today. Hints examination. When to use hints? A patient who has acutely dizzy, persistent vertigo, nystagmus, normal full neurological examination except nystagmus. Purpose to differentiate the central causes of acute vestibular syndrome, that is a stroke in posterior circulation, from the peripheral causes of acute vestibular syndrome, that is acute vestibular neuritis. What is hints? I have shown in this video here is a clinical bedside neurovestibular examination that differentiates the cause of acute vestibular syndrome, whether resulting from acute vestibular neuritis, a peripheral cause, or a stroke in posterior circulation, a central cause. The HI stands for the head impulse test, N stands for the nystagmus, and TS stands for the test of the skew. The first part of the examination, the head impulse test, tests the VOR integrity by observing the eye to maintain a fixed pointer in space during the disruptive head movements. A negative head impulse test is normal but is indicative of a central acute vestibular syndrome in the context of hints examination. A positive head impulse test is abnormal and is considered to be pathognomic of acute vestibular neuritis. The nystagmus is the most objective sign to distinguish between a peripheral acute vestibular syndrome from a central one. The peripheral nystagmus is usually unidirectional, mixed, horizontal torsional, while a central nystagmus is either vertical, or if it is horizontal then it is bidirectional gaze evoked, that is on right gaze it is right beating and on left gaze it becomes left beating. The test of skew is done by alternatingly covering and uncovering the each eye and looking for the deviation. A no deviation indicates a peripheral cause, that is acute vestibular neuritis, although in some cases it may be present. A diagonal or the vertical correction during the alternating covering and uncovering of the eyes indicates its central cause and is indicative of acute posterior circulation stroke. So, summing up the HINTS examination, the clinical signs, the head impulse test, nystagmus, and the test of skew. If head impulse is positive, the nystagmus is unidirectional mixed torsional horizontal and the test of skew is negative. If all three are present, it is indicative of a peripheral acute vestibular syndrome resulting from acute vestibular neuritis. And if any one of the three is present, that is a negative head impulse test, bidirectional gaze evoked nystagmus, or a positive test of skew, that indicates a central cause for acute vestibular syndrome. So, hence examination is not indicated in patients with distinct neurological symptoms and signs of extreme localizing value. Some of these are hemiataxia, ataxic hemiparesis, dysarthria, dysphagia, internuclear ophthalmoplegia, hemiparesis with cranial palsies, and highly localizing central nystagmi like convergence retraction nystagmus, periodic alternating nystagmus, and cross-coupling nystagmus. So, this is a person, acute vertigo. He also had a diplopia. And on right gaze, the abducting eye has a nystagmus and there is a adduction deficit in the left eye. So this is suggestive of left INO. Evidently, there was an infarct in the left dorsal midbrain affecting the medial longitudinal vesiculus. This is another patient with acute vestibular syndrome and mild gait ataxia. On eye closure, the eyes are deviated to his left, and on opening the eyes, there is a refixation to straight ahead gaze. This is fairly reproducible, and if there is a ipsipulsion to the left, in 9 out of the 10 cases, there will be an infarct in the ipsilateral dorsolateral medulla. And in fact, this patient had shown a initial negative MRI done within 6 hours, and when it was repeated after 48 hours, he showed a positive MRI. He also had a truncal ipsipulsion to the left. As you can see, he tends to fall to his left like a log of wood. The MRI delayed after 48 hours of symptoms shows left dorsolateral medullary infarct. Case history: 56-year-old female with acute vestibular syndrome. Hypertensive, neurooculomotor and vestibular examination, unidirectional right beating nystagmus, head impulse test positive to the left, skew deviation absent. Able to walk self and no gait or appendicular ataxia, no previous history of vertigo or headaches. This is the head impulse test which I am showing here at normal speed. You can appreciate a unidirectional right beating nystagmus, and on head impulse to the left, there is a catch-up saccade, but not to the right. The sign is reproducible. I have slowed down now the speed to the 50%. The clip speed is now 50%, and you will see a better catch-up saccade on head impulse to the left. Here it is. Not on head impulse to the right. Again, you can see here. So it is fairly reproducible. It is acute vestibular neuritis, which was earlier also called acute unilateral vestibular loss, and now it is called acute unilateral vestibulopathy, AUVP. This is a 73-year-old male seen in the second week of November 2024 with acute vertigo for 24 hours, vomiting and symptomatic at the time of examination. Head impulse test negative, so this should raise the alarm. Nystagmus bidirectional gaze evoked. On right gaze, right beating. On left gaze, it is left beating. So it has to be a central vertigo. Test of skew is present. This is the patient. On right gaze, you can see a right beating nystagmus, and on left gaze, you will see a left beating nystagmus. The horizontal gaze holding mechanisms in the midbrain, that is the medial vestibular nucleus or the nucleus prepositus hypoglossi, or the gaze holding enhancing structures in the cerebellum, that is the flocculus and paraflocculus. Any of the one of the or more of the four these structures have to be involved. And indeed, this patient also had a skew deviation. This goes down and that goes up. He had an infarct in bilateral cerebellum, and one of the infarcts on the right side was in the paraflocculus region. The basilar artery was irregular, and the bilateral posterior cerebral arteries were not visualized. Central patterns of the nystagmus: bidirectional gaze evoked. What is the eye movement machinery in the brainstem and cerebellum? There are five important structures. Generators of the saccades: vertical are RIMLF and horizontal are PPRF. Gaze holding is done by the interstitial nucleus of Cajal for the vertical or torsional gaze holding, and the horizontal is the nucleus prepositus hypoglossi and medial vestibular nucleus. The gaze holding is enhanced by the flocculus and paraflocculus. The saccadic accuracy is maintained by the oculomotor vestibular nucleus, and the nodulus and uvula are important for the velocity storage. These five key structures are important for these five key functions. 61-year-old male seen first in September 2023 and again in September 2024 with acute true vertigo, vomiting for 6 hours and symptomatic at the time of examination. The two things which were there were that he missed the morning breakfast in both times. Comorbid conditions: hypertensive, non-smoker. Neurooculomotor and vestibular examination showed bidirectional gaze evoked nystagmus, head impulse test negative, skew deviation negative. Able to walk self and gait or appendicular ataxia was not seen. Two episodes in similar 3 years were lasting few hours. On detailed questioning, he admits having episodic infrequent headaches lasting up to hours with vomiting prior to age of 50 years, which he attributed to acidity as per his family physician. So you can see a right beating nystagmus on right gaze. This is very clear. On left gaze, you will see a side pocket nystagmus. It is left beating plus down beating. Better seen here. So in any case, this patient suffers from vestibular migraine. It entity specifically known as epigone migraine vertigo, and I could see this patient the same nystagmus two times in past 2 years in September 2023 and September 2024. This is a 28-year-old female seen with recurrent vertigo, vomiting and unsteadiness lasting several hours and symptomatic at the time of examination. Comorbidities none. Neurooculomotor and vestibular examination shows bidirectional gaze evoked nystagmus, choppy smooth pursuits, head impulse test positive, skew deviation negative. Required one-man support to walk during the attack. 51-year-old mother accompanying her also had a gaze evoked nystagmus. EEG showed generalized epilepsy from discharges. She was being treated from elsewhere as a case of vestibular migraine without any significant effect. You can see on right gaze there is a right beating nystagmus. Here you see. And when she refixates straight ahead, there is a rebound nystagmus. You will see now. Yeah. On left gaze, you will again see a left beating nystagmus and severe oscillopsia. She is trying to close the eyes to avoid oscillopsia. Her mother, she was accompanying. She did not sought the consultation, but I called her to look for her eye movements. She also had a bilateral gaze evoked nystagmus. On left gaze, it is left beating, and right gaze, it is right beating. She complained of a similar illness, very mild in intensity, 2 to 3 times in a year, that she would ascribe to low blood pressure as she had been told by her family physician. So this patient was diagnosed as episodic ataxia type 2 because I could see the patient during an attack with her mother. She was treated with the acetazolamide dose up titrated up to 250 milligram 4 times daily, and she responded dramatically to it. 34-year-old female seen in March 2022 with acute vertigo and vomiting for a week and symptomatic at the time of examination. Comorbid conditions none. Neurooculomotor and vestibular examination shows spontaneous left beating nystagmus and a gaze evoked nystagmus on the right gaze. That is, a gaze evoked nystagmus is opposite in direction to the spontaneous left beating nystagmus. Head impulse test negative. Skew deviation negative. Able to walk unsupported. MRI brain with contrast showed tuberculoma in the right middle cerebral peduncle. She was treated with ATT for 18 months with 6 weeks of initial steroids, and a repeat contrast enhanced MRI brain after 18 months is normal. So this is the tuberculoma you see in the axial, coronal and sagittal post-contrast images. And this is the image on right gaze. There is a left gaze. There is a left beating nystagmus. And on left gaze, there is a left beating nystagmus. Besides a left beating nystagmus, which I could not demonstrate here in this video. In any case, there is a bidirectional gaze evoked nystagmus. So this has to be a central nystagmus. Nowhere in the Western literature you will find a acute vestibular syndrome resulting from tuberculoma in the posterior fossa. Periodic alternating nystagmus, though, is pathognomic of chronic lesions in the velocity storage mechanisms like nodular and uvula, but it has been reported recently from the acute lateral medullary infarction. This is the infarction. This is the nystagmus. You will see first a right beating nystagmus. It persists for a few minutes. Then there is a gap, and then it starts beating to the left. Again, left beating will be for 1 to 2 minutes. There will be a gap for half minute, and then it will reverse direction. Convergence retraction nystagmus is usually seen in the chronic dorsal midbrain pathologies, but it has been reported in acute dorsal midbrain infarct. This is the infarct you see, and you see the nystagmus here.
Guarda a destra.
In the Spanish, he is asked to see to the left and to the right.
A sinistra.
And straight ahead then.
Guarda me.
And when he sees straight ahead and converges, there is retraction of the eyeballs, and there is a disconjugate nystagmus. And this is highly suggestive of a dorsal midbrain syndrome. Acute in this case. Perverted headshake nystagmus in acute focal pontine infarct has been reported, and this is a very specific sign. However, this is a patient of acute Wernicke encephalopathy, which is one of the rarest cause of acute vestibular syndrome. First, you will see in a 48-year-old male who presented to emergency. He is an alcoholic. He had bilateral sixth cranial nerve palsy. He was unable to stand unaided, and you will see a bidirectional gaze evoked nystagmus with rebound nystagmus. On right gaze, it is right beating. On left gaze, it is left beating. Right beating on right gaze. Left beating on left gaze. He also had a vertical nystagmus elicited by up gaze, that is gaze evoked vertical nystagmus. Any vertical nystagmus in the emergency is always a central nystagmus. Here you see. Now the third pattern of the nystagmus seen in this patient is he is made to shake his head side to side in the yaw axis, and after shaking it for a few seconds you will see 1 to 2 beats of downbeat nystagmus, which is called the perverted head shake nystagmus, or it is called cross coupling nystagmus. This is the head shaking, and now you see the 1 beat here and a second beat thereafter. This is enough to make a diagnosis of cross coupling nystagmus, and this is highly specific for a central acute vestibular syndrome. However, it has also been reported in acute focal pontine infarct in year 2011. False negative MRI initial as well as delayed with positive central hints. This is a male who is around 70 years, seen by a cardiologist by acute vertigo, multiple vomiting and unsteadiness in the morning of 5th October 2024. MRI brain and MRI done on 6th October were normal. He was treated as BPPV by the cardiologist, seen by us on 25th October, almost 20 days later, with the residual symptoms, mainly unsteadiness. On right gaze, you can see a right beating nystagmus. Fairly reproducible. And on left gaze, you see a left beating nystagmus. So the pattern of the nystagmus is bidirectional gaze evoked, which is invariably a central nystagmus. and he also had a positive test of skew. This goes down, this goes up. He also had a abnormal tandem rhombox and tandem walking. He sways to his left when made to stand tandem and walk tandem. So, are there patients of posterior circulation stroke with false negative MRI? When I saw this patient, I searched the literature, and there was a literature of 2008 by Professor P.N. Sailaja when she published her study with the Canadian mentors. This is the diffusion weighted of the 6th October and 25th October, both are normal. So they've had performed MRI including diffusion weighted imaging on a 3 Tesla MRI in patients with stroke and transient ischemic attacks within 24 hours of the symptom onset and again at 30 days. So out of 401 patients, 103, 25.6% had initial negative diffusion weighted study. However, 6 out of 26 had infarcts on follow-up. So what happened to rest 6 patients? So if we remove 63 TIA patients which they found, around 20 out of 338, that is 6%, even had a negative delayed MRI at 30 days also. So 6% of MRI in posterior circulation will not be picked up even in a delayed MRI at 30 days, and that's how the HENS examination is, and examining the central pattern of the nystagmus is important for a general neurologist as well as a emergency care physician. So diagnosis of patients with acute onset persistent dizziness, ask and answer following 5 questions in the sequence. Is there is a central pattern of the nystagmus? A lot I have shown here. Is skew deviation is present? Is the head impulse test negative? Only applies to patients with spontaneous nystagmus. Are there any CNS signs on focused neurological examination? Is patient is able to sit or walk unassisted? If any of these questions is yes, consult a neurologist, perform brain and cerebrovascular imaging specifically to root out the vertebral dissection, admit for the stroke etiology workup, begin secondary stroke prevention if no thrombolysis is being done. If no answer, treat as vestibular neuritis, give steroids, prescribe symptomatic medications as histamines, but not for more than 3 days. Arrange early follow-up with neurology, primary care physicians, or neurologist. So, nystagmus pattern in acute vestibular syndromes in emergency departments. These are 2 important slides. Findings, significance, and comments. No nystagmus, normal findings. Rules out vestibular neuritis, but can occur in cerebellar stroke. Rarely, BPPV patients have continuous dizziness, but they do not have nystagmus at rest. Spontaneous horizontal nystagmus in primary gaze does not distinguish between the central and peripheral nystagmus, more commonly observed in peripheral causes, but is not diagnostic. Gaze evoked nystagmus that beats only in one direction, that is unidirectional gaze evoked nystagmus, does not distinguish between the central and peripheral causes of the acute vestibular syndrome. A peripheral cause is most likely but is not diagnostic. In neuritis, there is often a slight torsional component. A bidirectional gaze evoked nystagmus is always central, but there can be a benign central cause like acute alcoholic intoxication, phenytoin intoxicity, and a very occasional patient of episodic ataxia type 2. Pure vertical nystagmus in emergency is always a central finding. Pure torsional nystagmus is central, but the torsional nystagmus is expected finding in posterior canal BPPV, but that is a triggered acute vestibular syndrome, not a acute vestibular syndrome, spontaneous acute vestibular syndrome. Skew deviation is central. It's not very sensitive, but if present, it should be considered as a central cause of AVS. So spontaneous AVS, hence peripheral, no deafness, vestibular sedatives, early rehabilitation, and steroids, hence central deafness or ataxia, neuro workup. Stroke is more a possibility than Wernicke encephalopathy, and in rare cases, a multiple sclerosis may be there. No nystagmus, normal extraocular movements, no limb or gait ataxia, truncal ataxia, medical workup plus minus neuro workup. So how to triage these patients? Symptom timing segregates the transient from acute persistent vertigo. Hence, examination differentiates stroke from acute vestibular neuritis. Neuroimaging helps to determine the management and disposition decisions. So, acute vertigo in emergency, definite stroke, lysis candidate early with no neuroscience. Do a CT to exclude hemorrhage before lysis. MRI may be done later. The decisions are not based on MRI. Probable stroke not eligible for the lysis, late or no signs, less than 48 hours post onset. Observe or admit considered a delayed MRI. More than 48 hours post onset, MRI from the emergency department to dispose. No stroke, vestibular neuritis, negative, hence treat and discharge or admit for fluids with or without balance rehabilitation. The sensitivity and specificity of the hands examination in the trained hands is from 90 to 97%, and specificity is from 84 to 95%. In three situations, the hints examination is not useful. One is acute infarction in the parieto-insular vestibular cortex, that is the dorsal insula; acute embolic occlusion of the internal auditory artery, which is the AICA branch, leading to labyrinthine infarction; acute small infarcts in the cerebellar hemispheres. So the Italian people, they have found a way which is called a stunning protocol. They look for nystagmus by Frenzel goggles. If nystagmus is present, they see whether it is pluridirectional or vertical, and if it is a central vertigo. If it is unidirectional, they do a head impulse test. If it is negative, it is a central vertigo. If it is a positive, but the patient is unable to walk unsupported, this is a central vertigo. If there is no nystagmus but patient is unable to walk without support, this is a central vertigo. If there is a positional vertigo, they do a supine roll test and take salpike test, treat as BPPV. But if a BPPV patient is unable to walk without support, this is a central vertigo for all practical purposes, a central positional vertigo. My last slide on the otolith organs labyrinth, that is the trill translation ambiguity. I had talked about the velocity storage. The Einstein's equivalence principle is illustrated here for the otoliths. In the left row, in the left column, you see that during the backward linear acceleration, the initial force acts in direction opposite to the acceleration, causing otolithic membrane to lag behind the skull and sensory hair cells to bend. Similarly, the tilting of head forward, that is anti-flexion, causes otolithic membrane to sag and sensory hair cells to bend as they do during the backward linear acceleration. Therefore, the otoliths respond to both linear acceleration of head and head tilt to relative to gravity and cannot distinguish between the two. Here comes the role of nodulus and uvula, that is the velocity storage structures, and they make it possible to differentiate between the two. And this tilt translation ambiguity occur in many other day-to-day movements also. Thank you very much. I finished my lecture here.